horas e 30 minutos, né, pelo nosso regulamento. Vamos começar a nossa reunião, hoje recebendo uma figura pública, né, notória pela sua participação na cardiologia, na cirurgia pediátrica, na cirurgia cardiopediátrica, na cardiopediatria, né, uma pessoa que mudou os paradigmas, né, e que teve muito presente aqui nas nossas vidas, aqui no Brasil, na nossa geração, e que vai nos brindar hoje com uma conferência que eu sei que será extraordinária, como tudo que ele faz. E eu, por motivos superiores, vou ter que me ausentar aí no meio da reunião e vou passar a presidência da academia para o professor Lucchesi, que vai fazer a apresentação dele e coordenar aí todos os debates. Lucchesi, por favor, não seja golpista, né, para não me tirar o cargo dessa reunião.
Não, eu só vou usar a presidência só de 1 hora, viu? Já fico combinado com todos que se eu quiser permanecer, me tirem do ar. Está muito na moda esse negócio de tomar conta, né? O Bob saiu da imagem dele, o que houve? Perdemos a imagem do Bob? Hey, Bob, are you in?
Oh.
Hello, Bob. Oh,
yeah.
okay. You're there.
Here.
Okay.
Here
Bob, I have the mission to introduce you, which is not very difficult because we've been together so many times in life. But I would like to summarize your life in few words. I would say, from golf to congenital hearts and to international recognition. I'll explain. I first met Bob Anderson in Birmingham, Alabama. Remember, Bob, by the end of 1975. Dr. John Kirkling asked me to escort 2 prestigious visiting professors from Europe, Bob Anderson from London and Anton Becker from Amsterdam. At the moment, I could not anticipate that moment how much my life would be connected to these 2 gentlemen. Bob was an anatomist and Anton a pathologist. Kirkling was very enthusiastic about them. Bob graduated at the University of Manchester, and in this last year, he was so involved with his improvements in the training of golf that he asked to Professor George Mitchell from Anatomy Department the easiest task possible so he could spend some time or more time golfing. By the end of the period, impressed by Mitchell, he studied some hearts with, at the time, called ventricular inversion. Looking for the conduction system, he realized that the AV node was in different position, very distant to the place that everybody thought it was. Reason for so many AV blocks during surgical correction. Bob is very clever since then. He succeeded in golf, being included that year at the Guinness Book of Records for 2 hole-in-one in the same round. Fantastic. In addition, his first paper was a revolution in the knowledge of conduction system in congenital heart disease. Kirkling was so glad to have the visitors that he invited us for a lobster dinner, probably the very first big lobster that Bob ever had. I was witness of that moment. Bob gave by far, Bob, for sure, you gave by far the largest contributions to Brazilian cardiology, no question about it. To pediatric cardiology and adult cardiology as well. We organized together several courses in anatomy of congenital heart disease in different cities like Porto Alegre, Curitiba, São Paulo, Recife. Vera Yellow, who is with us tonight, remembers very well. She provided the hearts, so we could do a closed TV circuit and show the morphology of hearts. And I translated these 2 atlas with 10 fantastic pictures. And remember, Bob, we wrote a book together with Anton and Benigno Soto on morphology of congenital heart disease in the suite of Hotel Plaza São Rafael in Porto Alegre.
And, I remember it well.
Oh, yes, you worked with the fingers to the bone. Those were fantastic times. Lots of caipirinhas, gin and tonic, and wine bottles were the tools that helped us to do a good job. Brazilian cardiology, Bob, is very much indebted to you. Please accept the recognition of the Brazilian Academy of Cardiovascular Surgery and the gratitude, that's important, of hundreds of thousands of children that have the chance to survive due to the lessons that we all learned from you. Thank you very much, Bob.
It's a great privilege and pleasure for me to be invited to speak to you all in Brazil. It's many years since I've been to Brazil, but many of you know that at the beginning of my career, I spent very many happy weeks in different cities in Brazil, Rio, of course, Sao Paulo, particularly Porto Alegre. I visited Curitiba, and I had wonderful times. So thank you very much for giving me the opportunity to speak to you again on anatomy, the cardiac surgeon. And in a way, it's appropriate that you speak to me at the tail end of my own career, because I'm becoming very much a dinosaur. Now, why do I say that to you? When I started in my career, there's no question but that, or still calling it posterior. Well, good evening to you all, ladies and gentlemen. It's a great privilege and pleasure for me to be invited to speak to you all in Brazil. It's many years since I've been to Brazil, but many of you know that at the beginning of my career, I spent very many happy weeks in different cities in Brazil, Rio, of course, Sao Paulo, particularly Porto Alegre. I visited Curitiba, and I had wonderful times. So thank you very much for giving me the opportunity to speak to you again on anatomy, the cardiac surgeon. And in a way, it's appropriate that you speak to me at this end, the tail end of my own career, because I'm becoming very much a dinosaur. Now, why do I say that to you? When I started in my career, there's no question but that the gold standard, the understanding of cardiac anatomy, came from the dissecting room. And that's where I learned all my own anatomy. But things were far from perfect. Because in those days, we would take the heart out, we would position it on its apex, and we would describe things using what I now call the Valentine. Well, you in Brazil know that Valentine's Day is very important. Mardi Gras is a very important season for you all. But it's not so good for when we describe the heart. Nowadays, we have multi-detector computed tomography. And the experience we have with this new technique has revolutionized our understanding of not only the normal heart, but also the congenitally malformed heart. And that is because the virtual dissections we can do using computed tomography put the heart back into the body. So my own experience with cardiac anatomy has been totally revolutionized, subject to my collaboration with this man, Shunpei Mori. He is a Japanese cardiologist. Initially, he was working in Kobe. Now he has translocated to University of California in Los Angeles. This is Shunpei. This is a picture of him when he came to visit me now, several years ago, probably 6 or 7 years ago, came to visit me in London, and he told me he wanted to spend some time working with me I have worked closely together on re-appreciating the way that we dissect the heart. And I'm going to share with you today my latest views on cardiac anatomy that are largely due to my collaboration with Champagne. So I'd like to start with a few words about the need for attitudinally correct orientation. I am trained as an anatomist. Many people think that I'm a pathologist. I'm very fortunate that the pathology of the congenitally malformed heart is anatomical. So I started my career learning anatomy, teaching medical students anatomy. The first rule that I taught the medical students in the medical school, was that we should describe all structures relative to the body. And that means that the heart should be no exception to this, but sadly, when I started, that was not the case. Let me remind you what we mean by the anatomical position. This is the subject. The subject is standing upright. He is facing you. And this is how we should be describing structures within the body. We describe them relative to the three orthogonal planes. The coronal plane is the frontal plane. Sagittal plane, the second one in the long axis, runs from the front to the back of the body. And then there are any number of short axis planes. And these are the planes we use to describe what's going on within the heart. But we look at the heart in various fashions. So here, I'm showing you the body, the heart as it might be viewed by the cardiologist using the left anterior oblique orientation. But despite the fact that we can look at the heart, the left anterior oblique orientation, we should still describe it according to those three orthogonal planes. So in the frontal plane, we have the right side, the left side. In the sagittal plane, we move from the top to bottom, superior to inferior. And then in the third plane, we move from the front to back. And anything that is close to the spine, as you know, is posterior. Anything that is close to the sternum is anterior. And this is the way we should be describing the heart. So when we describe the heart, we put it back into the body, but we should not put it back into the body like that. So this is a cast of the heart I made quite some time ago now, and I've put it back into the body as we used to describe it. But this is not correct. This is not describing to you the heart as it lies within the body. When we put the heart back into the body, and when we describe it, we should describe it like that, as you see it, as you open the chest, and as you come upon it. And this is what we call attitudinally appropriate orientation. And one of the first things that I did with Champagne was to learn how to put the heart back into the body. Because what Champagne has done, he's taken his computed tomographic data sets and he has segmented them so that we can take the different parts and we can put them back into the body as they should be placed. So here you see, he's segmented the trachea, the two bronchuses, he's put in the esophagus in green, and he's marked in the location of the morphologically left atrium. And as you all know, the morphologically left atrium is the most posterior of the four cardiac chambers. And it is the left atrium that essentially anchors the heart within the mediastinum. And you can see very nicely there the four pulmonary veins that are coming together and forming the roof of the left atrium. And then we can put in the left ventricle. But the left ventricle does not point down. The cavity of the left ventricle essentially points from the back towards the front. And there we see it coming towards the apex beat. And then we put in the aorta. And the aorta is the centerpiece of the heart. And if we understand the aortic root, we understand all of cardiac anatomy. And eventually, I'm going to come back to the aortic root. But now, we can put in the right ventricle. And you begin to see the problems that confront us when we do not talk about things in attitudinally appropriate fashion. Because basically, the right ventricle is the anterior ventricle. For better or worse, we call it right ventricle, but there's very little of the left ventricle that protrudes leftward relative to this chamber. But we're going to call it right ventricle. To be sure we mean correct ventricle, we're going to call it the morphologically right ventricle. And then we can complete the cardiac silhouette by putting in the morphologically right atrium. And as you all see, it forms the right border of the heart. And in fact, when we have the heart in our hands, we can orientate it properly by making sure that the superior cable vein is directly above the inferior cable vein. But sadly, we did not do that in the bad old days when we took the heart out and we put it in the Valentine position. And it is the use of that Valentine position that has led us into bad ways. So many of you, hopefully, will immediately recognize that I'm showing you a short axis cut of the heart. It's a cut that's quite close to the base of the ventricular mass, but I have orientated in attitudinally appropriate fashion. So you see, its inferior surface, the diaphragmatic surface, is positioned inferiorly because this is down towards the feet. The opposite surface is superior. The part that is closest to the spine is indeed posterior. And there's a degree of angulation. So strictly, I should be saying this is posterior. Leftward, opposite that, we see the sternocostal surface, which is anterior. There, running along the middle diaphragmatic surface of the ventricular mass, you see that there is an artery. And one of the problems we have created throughout the larger part of my career is describing that artery in inappropriate fashion. Nowadays, using computed tomographic analysis, again, this is one of Schumpeter's computed tomographic images, we can show you the precise location of the coronary arteries. And this is what you as surgeons will be seeing all the time nowadays in your everyday experience. So there you will recognize the right coronary artery. And there you see the branches of the left coronary artery, the anterior interventricular artery, circumflex artery, which is running backwards through the left atrioventricular junction. And they are the three major coronary arteries. But there is another coronary artery. How should we be describing that artery? I lay odds, the greater majority of you will still be calling that the posterior descending coronary artery. But look at it. Ask yourself, is that artery truly posterior? Is it truly descending? And I hope you will answer that that is incorrect, because in reality, when we look at it again, and when we turn it, we look at it in the left anterior oblique position, you see that the artery is inferiorly located relative to its anterior counterpart. So we should no longer be describing this artery as the posterior descending artery. This was one of the problems of taking the heart out and positioning it on its apex in Valentine fashion. Nowadays, we should be describing what's going on in attitudinally appropriate fashion. There are further ramifications. This is one of the cuts of a computed tomographic data set that was prepared by another of my very good friends and colleagues, Tony Babarczyk, who works at the Medical University of South Carolina. And it's another cut that's almost in left anterior oblique projection. And there you see those two papillary muscles of the mitral valve. How do you describe those? I lay odds that you call them the septal than the anterolateral muscle. But that is incorrect, because the muscle that is closest to the septum is in fact inferior, and it is anterior to its counterpart. So nowadays, using attitudinally appropriate nomenclature, we should be describing the muscles as being inferoseptal and supernatural, because the computed tomographic data set does not tell lies. And there you see the box that gives us the precise orientation, telling us that muscle is indeed inferior and septal. And then we have to go one step further. This is now another of Shumpei's exquisite virtual dissections of a computerized tomographic data set. And let's look at the leaflets of the atrioventricular valves. How do you describe the leaflets of the tricuspid valve? Septal leaflet is easy, as it's adjacent to the septum. The second leaflet is anterosuperior. But what about that third leaflet? I'll lay odds, most of you are still calling it posterior. But it's not posterior. It's lying adjacent to the diaphragmatic surface of the heart. And nowadays, as we move into 2020s, we should be describing it accurately, and we should be calling it the inferior leaflet. And with the mitral valve, we have an aortic leaflet, and we have a neural leaflet. And if you use those terms, you describe their relationships. So the first thing I have to say to you is that my experience working with Shumpei, using these computed tomographic data sets, using virtual dissection, has revolutionized my understanding of the heart and how best to describe it. So nowadays, I put it to you all, if we are to make things easy to understand for those who are coming along, we have to describe things in attitudinally appropriate fashion, because that is how you see them when the heart is within the body, and that is the way you like to treat the heart. So now I'm going to take what I've learned with Shumpei, and I'm going to use it to explain how I now understand the remainder of cardiac anatomy. I'm not going to be able to talk to you in any great depth about the coronary arteries because we simply don't have time. So what I'm going to talk about is the atrial chambers. I'll move on, I'll talk about the ventricular mass, and I'll concentrate on the arterial roots. And in between, I'll say a little bit about the septal structures. So I've learned a lot about the extent, or rather lack of extent, of the septal structures, and I will touch on the conducting tissues. There are so many things I'd like to tell you about, but time is limited. So let's move on. What have I learned about the atrial chambers? Well, for starters, I've learned that each chamber has part that we're going to call the body. It's much smaller, the right ventricle, than the left ventricle, and I'll try and explain why. I've also learned that the most important part of the atrial chambers is the appendage, because it is the extent of the pectinate muscles, as I'm going to show you, that permits us to distinguish between the right and left atrium when the heart is congenitally malformed. You all recognize the venous component, so I'll touch on that. I'll introduce you to another part, which you see all the time, you probably don't describe, maybe the vestibule, and then, as I say, I'll touch on septal structures. So let's look at the morphologically left atrium, because that shows us very beautifully all of these component parts. You all know about the pulmonary venous component. That is the back part. As I say, we'll look at it again very shortly, but more or less anchors the heart within the mediastinum. The appendage on the left side is tubular, it is hooked, and significantly it has a very narrow junction with the remainder of the atrium. So you see very little of the pectinate muscles on the left side. There is the vestibule, it is smooth, but the left atrium is dominated by the body, and the body is walled. And then on the septal surface, we see the horns of the flap valve of the oval fossa. So I show you the left atrium first, because we can very nicely see all these 5 components. We put it back into the heart. As I've shown you already, it is the most posterior of the 4 cardiac chambers, and it anchors the heart into the mediastinum by the attachment of the pulmonary veins, with the pulmonary arteries also coming forward and serving to anchor the heart within its pericardial cradle. So that was the left atrium. You won't be surprised to know that we analyzed the morphologically right atrium in exactly the same way. But now the difference is the extent of the body. Most of the body belongs to the left atrium, because that is the building block of the left atrium. It is there from the outset. The larger part of what we see in the developing heart stays within the morphologically left atrium. So this is what the right atrium looks like. I've opened it by making quite an extensive incision along the wall of the atrial appendage. It's parallel to the terminal groove. And when you open it out, you see all those pectinate muscles. And this tells you something that often is not appreciated. The entirety of the anterior wall of the right atrium is made by the appendage. Within the back part, however, we see the venous valves. And it is the venous valves that show us the boundary between the systemic venous sinus and the remainder of the atrium. So coming into the systemic venous sinus, we have the superior caval vein.
Perdemos o som, Paulo.
The right atrium, rather, having extended to the left atrial groove. The 3 of them together make up the systemic venous sinus. But the feature of the right atrium is the extent of the pectinate muscles which mark the appendage. And in fact, the pectinated part interposes the smooth-walled vestibule, the smooth-walled venous sinus, and there in the back we see the septum. And there is a tiny part of the body that comes into the right atrium. And in this particular example of the right atrium, you can see the left venous valve, and the body is the small part between that left venous valve and the septum. We can see what's going on rather better if I show this cast of the left atrium. And now, very nicely, you see the extent of those pectinate muscles, showing you that the entirety of the anterior wall is indeed made up of the appendage, which interposes between the smooth vestibule, the smooth venous sinus, receiving superior caval vein, inferior caval vein, and coronary sinus. And again, another Tony Lavacek's exquisite computed tomograms. Now you can see the same thing during life by making virtual dissections of living data sets, confirming the extent of the pectinate muscles, which run all the way round the vestibule. This, of course, is how I have seen it over the years. And now it's not quite so easy to see that the entirety of the atrial wall anteriorly is made up of the appendage, but we can see its crest, we can see its relationship to the superior caval vein, and now we can build up, we can see that junction between the appendage and systemic venous sinus, which is the terminal groove. And I said I would touch upon the conduction system, because having identified the terminal groove, there lying with it, close to the crest of the appendage, you should all know is the location of the sinus node. And if you stay out of the terminal groove, particularly adjacent to the crest of the appendage, you will avoid damaging the sinus node. And you all know how important it is to avoid the sinus node. So let me return now to the inside of the atrium, because on the inside, matching the terminal groove on the outside, we have the terminal crest. And this particular dissection shows you exquisitely the extent of those pectinate muscles. As I say, they line the entirety of the anterior wall of the right atrium. But now I can show you some more important features. At the top of the terminal crest, we have the spurious septum. In the back of the left atrium, we have the oval fossa. I'll come back to that in just a moment. But as we look on that surface, we can see more important features. We can see the remnant of the eustachian valve, which we call the eustachian ridge, that guards the mouth of the inferior cable vein for fetal development. And there you see the Flabesian valve, which is guarding the mouth of the coronary sinus. They come together and they form an important structure. And that structure is the tendon of Todaro. We can trace that forward to the septum. We can draw another line formed by the hinge of the tricuspid valve, and that shows us the crucial area that you all know as surgeons you must avoid, and that is the triangle of Koch. And there at the apex of the triangle of Koch, we find the site of the atrioventricular node. As you all know, it's invisible during life, but if you know these boundaries, if you stay out of the triangle of Koch, you will not damage the atrioventricular conduction axis. Now, I can't finish talking about the atrial chambers without telling you about the atrial septum. And in saying that, I must distinguish between the parts of the walls of the heart that you can take away without exiting the cavities, as opposed to those parts that are folds or sandwiches. If you go through there, you go outside heart. I can show you that with another of Schumpe's very beautiful computed tomograms. You'll recognize that it's a four-chamber cut, but I've orientated it as it would be in heart. So there is the right atrium in front of the left atrium, and there you see the site of the oval fossa. And that shows you a second true septal structure. In fact, the larger part of the septum. And that is what I'm going to call the buttress. And the buttress is the true second septum. The fold that everybody at the moment calls the septum secundum is, in fact, the interatrial fold. And as I'll show you, as you see in this image, it is posterior, but it also extends superiorly. And for a long time, I thought this second area was a septal structure. We used to call this the atrioventricular muscular septum. We now know it is a sandwich, because interposing between the atrial wall and the ventricular wall in this area is an extension of the inferior atrioventricular groove. This just shows you how accurate we can now be with virtual dissection. This is a proper dissection made by another close friend and collaborator of mine now, Diane Spicer, who's a pathologist assistant, but is a superb anatomist in her own right. So again, you see the left atrium, there you see the mouth of the inferior cable vein, and that shows you this buttress is the true second septum. There is the floor of the oval fossa, that valve, and that, of course, is the primary atrial septum. But you see, forming the posterior margin, we have a fold rather than a septum. And Diane has done rather a nice dissection that shows you the true extent of the atrial septum. So here you're looking at that septal surface. Again, I'm showing you the heart in attitudinally appropriate fashion. And what Diane has done is she's cut away all the parts that are not septal. To orientate you, there is the superior cable vein, the inferior cable vein, the mouth of the coronary sinus, and there is the true second septum, the anteroinferior buttress, and running through it, you see the eustachian ridge that becomes the tendon of Todaro, the hinge of the tricuspid valve. There again, we see the location of the atrioventricular node. So the floor of the oval fossa is an obvious septal structure. But what about all these other component parts? So what Diane now has done is she has cut away everything that is not septal. And what do we have left? We have the floor of the oval fossa. We have the anteroinferior buttress. But everything else is a fold or a sandwich. So there she's taken away the atrial wall of the triangle of Koch, showing you that beneath it is the inferior pyramidal space. People talk about the so-called sinus septum, but again, you can see behind there we have fat. There is the posterior fold I've already shown you, and there is the superior fold, which at the moment is called the septum secundum. In reality, it is the superior interatrial fold. So let's move on, because we need to look at several other things, and we're going to look at the ventricular mass. It extends from the atrioventricular to the ventricular arterial junctions, and almost without exception, it contains two ventricles. When I started in the field, there was arguments as to how best we should describe the ventricles, but now we know they are best described as having inlets, apical trabecular, and outlet components. We can see that very well in the right ventricle. It extends from the atrioventricular to the ventricular arterial junction. And there we see its inlet, the coarse apical trabecular component, which serves to distinguish it from the left ventricle, and the extensive muscular infundibulum. We could see it particularly well with computed tomographic analysis, the atrioventricular junction, the ventricular arterial junction, an inlet, apical component, and there very nicely you see freestanding muscular subpulmonary infundibulum with a supraventricular crest interposing between the leaflets of the tricuspid pulmonary valve. Again, we can show it to you with true dissection, because I can now show you more of those features. There is the supraventricular crest, inserts between the limbs of the septomarginal trabeculation. But these other structures become important when we make comparisons with the congenital malformed heart. So there we see just some of the septoparietal trabeculations, one of those being the moderator band, which gives rise to the large anterior papillary muscle. All of these are important structures. So if we turn our attention to the left ventricle, which again extends from the atrioventricular to the ventricular arterial junction, it has an inlet, an apical trabecular component. But now the apical trabecular component is fine and crisscrossing. And it is this part that best serves to distinguish between the ventricles when they are congenitally malformed. There is the outlet. The outlet supports the aortic root, rather, and I'm going to finish off talking to you about the significance of the aortic root. Much has been written about the ventricular septum, and much of it is wrong, because it only has muscular and membranous components. When I started in my field, I would describe the outlet septum. I know it no longer exists, because the so-called outlet septum is in fact the freestanding muscular subpulmonary infundibulum. I can show you the extent of the membranous muscular parts best when I show it to you from the left side, because here the membranous part has been transilluminated. This is an image made by another good friend and colleague of mine, Damian Sanchez-Quintana, who spent time with me at the Brompton Hospital and did this wonderful work when he returned to the University of Badajoz in Spain. And there you see another part of the left ventricle, the inferoseptal recess. I'm not going to have time to talk to you about the implications of this entity. But what we can see is that the inferoseptal recess is roofed by an area of mitral to tricuspid continuity that is continuous with the membranous septum. And I've marked in the left bundle branch because it penetrates through that area of mitral to tricuspid continuity. And there is an important point here. because for you as surgeons, when you are replacing the aortic valve, you need to be very well aware the closest the conduction axis gets to the aortic root oftentimes is the nadir of attachment of that right leaflet. But you can't see the conduction system. You do need to know where it is. So when you're looking right side, we put in again the landmarks of the triangle. Tendon of Todaro, hinge of the leaflet of the tricuspid valve. The atrioventricular node is at its apex. We draw a line to the medial papillary muscle, and between the two, that is where we are going to find the atrioventricular conduction axis. Avoid those areas, and you will not damage inadvertently that crucial component of the heart that is responsible for normal atrioventricular conduction. So let me finish by moving on to the arterial roots. If we are properly to understand the arterial roots, we have to appreciate the interrelationships between their leaflets and their supporting sinuses. And these are best seen in the pulmonary root, and that is because of the support found in the pulmonary root provided by the complete muscular subpulmonary infundibulum. Here's a dissection I made a long time ago to show you that freestanding muscular infundibular sleeve. You'll recognize we're looking down on the aorta. I dissected the tissue area between the aorta and the pulmonary trunk. And you see that extensive extracavitary tissue plane, and now that shows you beautifully the infundibulum. We should have known about the existence of the infundibulum for a long time, and all of you who are surgeons should know about this, because you are all well aware you can take away the pulmonary root and you can use it as the autograft in the Ross procedure. And that in itself tells us there is no muscular outlet septum. If there was a muscular outlet septum, we would not get this sleeve of freestanding infundibulum left behind after we had removed the pulmonary root. There we see the extracavitary tissue plane. But I want to look inside, and I want to look at the pulmonary root. So this is what it looks like having removed the leaflets of the pulmonary valve. And that is a key procedure, because now you can see the anatomic ventricular arterial junction. This is where the myocardium, subpulmonary infundibulum, gives way to the fibroelastic walls of the pulmonary trunk. And what you note is that the semilunar hinge of the leaflets of the aortic valve, the pulmonary valve rather, cross that anatomic ventricular arterial junction. And they are anchored distally at the sinutubular junction. There are 3 leaflets, and because of their semilunar attachments, we have 3 crescents of myocardium that are incorporated at the base of each of the sinuses of the pulmonary trunk, and there are 3 triangles of fibrous tissue that reach up to the sinutubular junction. And that means that what the echocardiographers call the valvar annulus doesn't really exist as an anatomic entity. And that's why now we call this the virtual basal ring. And that permits me to tell you that the arterial root extends from that basal ring to the sinutubular junction. You've already seen that the leaflets are attached within the root in semilunar fashion. And the key to understanding is the interdigitation between sinus and ventricle. So there is no ring-like annulus. In fact, the leaflets are attached in the form of coronet, and in the pulmonary root, all of those leaflets are exclusively supported by myocardium. So if I build up the root, these are those semilunar hinges. And to me, that looks like a crown or a coronet. There are rings. The sinutubular junction is a ring. The basal part does not exist anatomically, but we can create a ring. And in the pulmonary root, there is a 3rd ring, and that is the anatomic ventricular arterial junction. which structure is the annulus, you pays your money and you takes your choice. And indeed, the questionnaire was organized quite some time ago now by German surgeons. They sent a questionnaire to many surgeons around the world. Some of you may well have answered that questionnaire, and there was no agreement as to which of these rings should be considered the annulus, or whether you as surgeons would better consider the semilunar hinges of the leaflets of the valves themselves. The important thing is to distinguish between the leaflets, sinuses, and to describe what you see. As the German surgeons pointed out, in 2012, nomenclature was a Tower of Babel. I think things have moved forward by then, so now we can look at the aortic root and we can make sense of it thanks to the advances that have been made by computed tomography. So here we are, back to one of Stumpé's reconstructions of the aortic root. There you see it. I've already told you. It is the centerpiece of the heart. Superior and leftward, we have the pulmonary root. The non-adjacent sinus of the root interposes between the tricuspid valve, the mitral valve, and beneath that, we have that inferoseptal recess that time has not permitted me to describe in detail. It overlaps the inferior pyramidal space, and if you understand the relationship between the two, then you will better understand the location of the atrioventricular conduction axis. But sadly, we don't have time to go into those details, so I'm going to finish by telling you about the aortic root, which interposes between the left ventricle and the infundibulum. And again, it is dominated by the semilunar attachment of its leaflets. And when we look at the attachments of those leaflets, we can identify the sinotubal junction at the other end. We can create the virtual basal ring, but there is nothing there. It is truly a virtual entity. How should we describe its components? To me, I talk about the leaflets. They are the moving parts, and we find them not only in the arterial valves, but also the atrioventricular valves. The key point is to distinguish between the leaflets and the sinuses. And it is the sinuses that house those leaflets in semilunar fashion. We also need to recognize the zones of apposition between the leaflets. And we see those best when the valve is in its closed position. The superior ends of the leaflets come together at the sinutubular junction, and that is what you will call the commissures. But then you also have to recognize those zones of apposition, because the valve will not work properly unless they fit snugly together. So where is the annulus? Is it the semilunar attachments? Is it the virtual ring? It is up to you. My recommendation is you distinguish between those two entities, because you can see them now so beautifully using the virtual dissections, as you see again in one of Stumpé's offerings. Now we're looking at the left side from the heart, from behind. So you see the left atrium with its pectinate muscles, left ventricle, the infundibulum. And there between them is the aortic root, extending from the sinutubular junction to the virtual basal ring. And now what Stumpé has shown you is how myocardium is incorporated in two of the sinuses of the aortic root. And those are the sinuses that are adjacent to the pulmonary trunk, and they are the ones that give rise to the coronary arteries. We can look down on it in a virtual data set. So there is the right coronary sinus, the left coronary sinus. The third sinus does not give rise to a coronary artery in most instances, but on occasion it does, and that's why I call it the non-adjacent sinus. And there at the base of the coronary sinuses, you see that myocardium that has been incorporated by virtue of the semilunar attachment of the leaflets. There is no myocardium, the third sinus, which is non-adjacent. But Champay is also able to show it to you by reconstructing those rings. So there is the root extending between the sinutubular junction and the virtual ring. But note now how there is that minimal extension within the aortic root of the ventriculo-arterial junction. And that is because there is only myocardium incorporated at the base of coronary sinuses, the aortic sinuses that give rise to the coronary arteries. So if I put that all back together again now, but showing you those rings, sinutubular junction circular, there is that extension of the anatomic junction. But there is another interesting point. The so-called annulus, the basal ring, is in fact ovoid and is far from being a true ring. But there, however, are those segments of myocardium that are incorporated at the bases of the two aortic valvular sinuses that are giving rise to the coronary arteries. And this, of course, is how you see it in a two-dimensional plane, but it gives you all the information you need to know about the aortic root, which extends from the sinutubular junction, virtual basal ring. But now look where we see the leaflets within the root. They don't quite reach up to mid-sinusal diameter when they are in their closed position. The group from Hamburg, however, have shown how important it is to be able to measure the dimensions of the leaflets and to distinguish between their geometric height and their effective height. And nowadays, all of this information is directly at your fingertips, thanks to the advances that have been made by the availability of computed tomography. So if I summarize everything, to me, the virtual dissection of living data sets has totally revolutionized, I say, our understanding, not only my understanding, but hopefully your understanding as well. Now you are in a very fortunate position, because all of this information throughout my career, I've had to work at, dissect the hearts, to bring it to life. Now it is all revealed by virtual dissection of computed tomographic data sets. Thank you for letting me share this experience with you. And hopefully I've been able to tell you how things have changed over my lifetime. Anatomy has not changed, but for sure, our understanding has improved so much and continues to improve thanks to the revolution produced by virtual dissection of living data sets. Thank you so much for giving me the opportunity to talk to you.
Thank you very much, Bob. In fact, it's fantastic. This virtual dissection is a big surprise for us surgeons. And also, the aortic valve and the aortic roots today with the transcatheter valve implants. That's an area that we really need to know more about. And thank you very much for your contribution. I would like to hear now the comments of Professor Salerno.
Well, Bob, it's such a pleasure to meet you. I have heard so much about you. You have contributed so much to some of my work. This is an outstanding lecture. You call yourself a dinosaur. You are a living legend, a living dinosaur. I wish I would have met you 30, 35 years ago so I could have learned anatomy that I apply every day in the operating room. This lecture of yours opened my eyes to normal hearts and something that I some way did not know or did not quite understand. But I can imagine the knowledge you have and your contributions you made for congenital heart surgery. I mean, you spend about almost half an hour talking about the root of the aorta. Imagine you talking about congenital heart disease. as I listen to your lecture, I really believe that every single surgeon should listen to this lecture. Every single medical student in the anatomy department should listen to this lecture. It's a fabulous understanding of the anatomy in a manner that I could never dream it would be like this. Brofman and the group of the Academy have said that this is going to be a great lecture. This Academy is made up of the leading cardiac surgeons in Brazil, create this Academy. It'll be remember for the future of the history of heart surgery for those who contribute so much. We invite leading speakers to our group to enhance our knowledge and understanding. You have contributed greatly to our understanding tonight. My opinion, my admiration for you is of such a magnitude that it's hard to describe. And I think I can share my feelings with all my cardiac surgeons in Brazil. I want to thank you very much for participating in our academy. There is something else coming, but I want to say many thanks for being here with us. You enlightened cardiac surgery in a manner that I could never imagine. Thank you.
Oh, thank you. If I can say a few words to respond to your very kind comments, because you made some very significant points. You've emphasized how we should bring this information to the medical students. And I think perhaps that is the most important thing that you've said, because nowadays using virtual dissection and doing what Murray did by putting back those components of the heart into the chest, it is so easy now to teach cardiac anatomy to medical students. And more important than that, to do what we have not done in a larger part of my career, to take the heart out, to describe it as though it's on its apex. Because nowadays, you know full well, all of you cardiac surgeons, you see three-dimensional data sets from living patients, and that information is given to you in attitudinally appropriate fashion. So we have to start describing things attitudinally, and we need to start with the medical students. And if we can persuade the medical students to describe things properly, then hopefully things will trickle up. And I thank you so much for your comments. You are correct. I could have spoken to you for several hours or more than several hours, but the time did not permit it. But I welcome your comments and I thank you for them.
Thank you, Bob. I think that we move on. I could also call at this moment Manuel Antunes to say a few words.
Fernando, me perdoe,
Yes,
Ricardo.
No, I know that. But we need to do a big end, you know. Then we open to the other guys. Manuel, if you have some words to say, this is the moment. Turn on your microphone.
Yes, I was also amazed with this lecture. I had met Professor Anderson first time in Johannesburg. It must be some almost 40 years ago. And I met him many times in his anatomy demonstrations in the congresses of the European Association for Cardiothoracic Surgery. Not in the more recent ones, but in those a decade ago. We learn all the time. What can I say? I must, however, confess that sometimes we surgeons don't see the heart exactly like that. It's that's why it's important to listen to a talk like this, so that we can see it not only the way our eyes look into it, but also how we should construct the three-dimensional image, which our eyes cannot reach every time we open through a limited incision and only see a little portion of it. But this is fantastic. You know, you don't know, Professor Anderson, this, but we had a working session of the board last week, and we were prepared. At that time that we had the session, your session had already been recorded, so we were told to be prepared for an amazing thing, and that's exactly what we heard tonight. Thank you very much for your excellent presentation.
Thank you, Manuel. Thank you. Bob, those two are our honorary members. Salerno, working in Miami, and Manuel Antunes, working in Coimbra, Portugal. Now, we have a special moment for this lecture. Dr. Ricardo Lima, our friend from Recife, you know him very well. He wants to make something that you probably enjoyed. Let's see, Ricardo.
I would like to thank the Brazilian Academy of Cardiovascular Surgery for the opportunity given to me to pay this tribute to you. I confess this is a very important moment for me, having the opportunity to provide the one who was my teacher 4 years ago in England. In 1983, I had the opportunity to work in your laboratory of cardiac morphology at the Brompton Hospital, London, England, and I never imagined that today I would have the pleasure of granting you the title of honorary member of the Brazilian Academy of Cardiovascular Surgery in the names of all academics. The Brazilian Academy of Cardiovascular Surgery NU regiment aims to contribute to development and progress of medicine and related science, encourages the improvement of medical cultures, the profession, ethics, medical education, social medicine, and preserve medical memory in general. Professor Anderson, you was responsible for demonstrating the location of invisible conduction tissue within a clarify the morphology of congenital malformed heart, played a large part in permitting surgeons to improve the results of pediatrics and cardiac surgery all around the world. Professor Anderson, your contribution to the introduction of an extraordinary, new and simple way to describe and understanding the morphology, alteration of the heart, and congenital heart disease, helping thousands of physicians identification of congenital defects, played a large part in permitting surgeons to improve the results in pediatric cardiac surgery. According to the Brazilian Academy of Cardiovascular Surgery regulation in Article 11, it says, honorary academics are considered Brazilian or foreign medical personalities recognized for their notorious knowledge by proposal of the board or by the 1/3 of the founding members and full academics, and after approval by the General Assembly. This honorific title was approved by 100% of our General Assembly. As of today, we will join the other honorary members of the Academy, such as Thomas Salerno from USA, Frederico Benetti from Argentina, Manuel Antunes from Portugal, and Rudolfo Neirotti from USA. Professor Anderson, my most sincere congratulations for this deserved honor. Congratulations. Thank you.
Descompartilhe agora lá em cima, Ricardo. Isso, perfeito.
Thank you. I'm overwhelmed by this honorary title that you have granted me, and I shall carry it forward. And I hope that I am able to continue to contribute. As Professor Salerno said, we all still continue to learn. We all still have so much to do. I see that Vera is with us at the moment, and it's nice to see you there, Vera. You were kind enough to invite me to the recent meeting, which I was not able to come to just ahead of the pandemic. But who knows, when the pandemic eventually releases its grip again, then maybe it will be possible for me to return to Brazil and to meet all my friends again and to say thank you for this signal honor that you've conferred upon me today. And I also say what a pleasure it is to see Rodolfo there. It's a long time since I've seen Rodolfo, and it's an honor for me to join Rodolfo as an honorary member of your academy. Thank you.
Hi, Bob.
Hey, Rodolfo.
Nice to see you. I mean, really, all these days that we were discussing your visit, I had been together with Maria Teresa, remembering the time that we spent together in in Amsterdam, in one of the meetings in another places with you, and particularly the meeting in Buenos Aires, as you might remember, with John Kirkland, you, Anton Becker, Beku, and Bob Friedel.
Indeed, I remember that well, 1978. It was a wonderful meeting.
Yes, yes, we do.
We were young men then, Rodolfo.
Yes, yes, we are. I mean, you may become getting older, but not me. Anyway.
Well, good to see you again.
Yes, yes. I'm sure Maria would be very happy to know that I had the chance to have a word with you.
Thank you.
All the best. All the best.
Thank you very much.
I still remember once that there was a wine tasting at the Brompton Hospital, and then there was a table with the most expensive wine there. So I was invited, and I was there, walk around and stand in front of the most expensive bottle and drank the whole bottle. And you didn't like it. This is the wine taste. This wine is not supposed to be drink. So there you are. I remember that. Anyway, and also when the celebration or the retirement of Professor Becker. Remember, we had that meeting in Amsterdam. That was wonderful.
Indeed. Thank you.
Thank you.
Fernando, you're muted.
Oh, yes, this is Paulo Brofman that makes everybody mute. I was saying that it's very nice to hear Vera Yellow now also, since we've been together so many times in our courses here in Brazil. Vera, please.
Good night, good evening, everyone. It's a pleasure to be invited to this meeting with Professor Anderson. As always, an outstanding presentation, Professor Anderson. Congratulations again. You know that I am your #1 fan, #1. And well, I would like to ask you about your recent commitment with the new terminologia anatômica, new anatomical terminology. And do you believe there will be the chance that this attitudinally corrected orientation nomenclature will be incorporated in the new version of the Terminologia Anatomica?
I am certain of that. The organizers of the anatomical nomenclature now are convinced that the attitudinal approach is the way to go. You know that in our own nomenclature committee at the end of June, we will discuss this. And the second version of anatomical terminology now has the attitudinally appropriate terms. And I hope we will also incorporate them into our own nomenclature when we discuss that. And your support in that regard will be very important. But I am sure that with regard to the anatomists themselves, we will move forward. It will take time, but in the fullness of time, as more and more people see computed tomograms, see magnetic resonance imaging, three-dimensional echocardiograms, it just makes no sense anymore to use these outdated terms. It will take time, but eventually we will succeed.
Bob, I would say that Fabio Jatene is with us and keeping a beard because he wants to look older, you know. And yeah, it gets more authority over the guys in court in São Paulo. Fabio, do you want to say some words?
Good evening, everyone. Professor Anderson, is a great opportunity to see you again.
Well, thank you.
I say thank you very much for the Academy for this opportunity. I had the privilege many years ago to stay together with you and Vera Aiello in many of your presentations in Brazil. At that time, if you remember, we tried to provide to you some anatomic specimens for your presentations. So it's a big privilege to see you again, to hear about you. This fantastic presentation is a big pleasure. I learned a lot at that time. I learned a lot together with you in your presentations at that. Thank you very much for this enormous privilege.
Well, I remember the occasions well that you described. We had the wonderful hotel in Rio, where we had the meeting, which was delightful. And then in Fortaleza, we had a marvelous time in Fortaleza. And now, what is most encouraging is to see Vera continuing to demonstrate and to show these hearts and to carry on the good work that we started. And I think you're doing a great job in INCO. And I think Vera's contribution keeps things moving in the correct direction. And as you say, we started it a long time ago. It's good to see that we're moving in the right direction. Thank you for that.
Thank you, Bob. I think that, what time is it in London now, please?
It is 10 to midnight. So
10 to midnight. We should to send you to bed, but
you
anyway,
should indeed.
Yes. Well, I think that, you know, it's been a fantastic evening. Thank you very much for your time. In fact, in two times we had a nice time last week when you recorded everything, and now again with us. We need you back. Really, as soon as the pandemic time goes over, we think that we should come back and to rebuild one of the old courses that we started here. That was the beginning of your career, and we are so proud to participate on that. I think that we should finish now. I think that many people would like to talk, but unfortunately, it's midnight in London. And Bob, thanks a lot. Thank you very much indeed. Your final words, please.
Well, thank you so much for having me give this lecture, but great thanks in particular for granting me the honorary membership of your academy. It is a privilege for me to join you. And if it is possible for me to return, I've always enjoyed myself in Brazil, and it would be great to come back and see you all again and to catch up with some of the caipirinhas.
Okay, great. Thank you very much, Bob.
My pleasure.
Bob, thank you very much. Thank you to see you again.
Paolo,
Thank you.
Thank you for organizing the whole thing.
I'm sorry the problem, but everything's okay. Thank
Excellent. Thank you so much.
you. Bye.
Good night.
Good night. Thank you.
Good night.
Adeus a todos, boa noite. Boa noite,
Boa noite,
aqui de
Manuel.
Portugal também.
Boa noite,
Boa
boa noite,
Boa noite, Fábio. Boa noite a todos.
Boa noite.
boa noite, todo mundo.